So I want to start just by talking a little bit about, what brings me here, and then I want to talk about what brings you guys here. And let me just explain who I am, and then we can talk about a little bit about specific issues that you folks have. So, of course, my name is Steve Manlove. I'm a psychiatrist. I've been practicing in Rapid City since 1987, forever, sort of. I've done general psychiatry and geriatric psychiatry and child psychiatry and forensic psychiatry and consultation and inpatient, about everything you can do in the Rapid City area. Um, and about 2015, I had a sort of a midlife crisis and decided that I needed to do something different and began to look around and see what would be interesting to me and what would be fun, what would be needed, and ultimately decided I really wanted to try treating people who I'd never been able to treat well before. My hope was that doing, maybe some of the knowledge that I had from before, I could use to focus on people who I hadn't really been able to treat. And it turns out um, something like 30% of people with depression don't respond to standard treatments. And by that, I mean routine antidepressants and psychotherapy. So it's a big number of people who don't respond to those things. And of course, that's what I'd been doing all of my life, and it was what I knew to do, and it's what everybody was doing at that time. So the question was, what else might there be to do? Is there some other way of going at this? So in about 2015, I started looking around and decided to stop doing inpatient psychiatry and ran into transcranial magnetic stimulation, which had been FDA approved in 2008, and decided that might be a different way of going at depression. So I began doing transcranial magnetic stimulation in my office, and we had really, really great results. It was sort of surprisingly good and these were for people who I'd been seeing for years who had not been doing any better. And so that was exciting. Around that time, I also began to kind of think about ways we could make transcranial magnetic stimulation work better. I noticed serendipitously that people who exercise contemporaneously with TMS seem to do better. That led to a deep dive into exercise physiology and effective exercise on the brain. And of course, I ran into uh, a hormone that y'all probably have heard of by now, but I hadn't heard of then, which was called brain-derived neurotrophic factor. Turned out exercise stimulates increase of brain-derived neurotrophic factor, and or BDNF. And then, so just to kind of break that down a little, brain derived from the brain, neuron trophic growth. So brain derived neuron growth factor. This is a natural hormone that your body makes. It happens to be stimulated by exercise, amongst it, and other things also. I looked at the physiology of TMS a little bit more and recognized that TMS also stimulated the release of brain-derived neurotrophic factor, and it became apparent then that there was maybe some synergy between exercise and TMS. So that was interesting to me, and it led to another tangent of study looking at what else might affect brain health, brain trophics, neuron trophic growth. So got into a deep dive into the dementia literature, which really was all about improving brain health and improving neuronal growth, and began to do a lot of work with brain health contemporaneously with our TMS work. So I guess I point these two things out because they're two kind of cornerstones of my thinking right now. One is TMS, the other is brain health, how to improve brain health. It sort of makes sense when you think about it that if you can make the brain healthier, it's more likely to respond to any treatment. This sort of seems logical, and I think that my studies of ourselves has proven that to be true. Around 2018, I became interested in ketamine. We began doing ketamine treatment in my office. And really, we were finding that TMS worked well, but it didn't help everybody. So there was about maybe 25 or 30% of people with treatment-resistant depression who didn't respond to ketamine, so looking for another option. So ketamine, they didn't respond to TMS, so ketamine was another option. So we began doing ketamine, and then in 2019, the brand name form of ketamine, or Spravato, was FDA approved. So that kind of opened the door for getting some insurance coverage of a ketamine-like drug, which was Spravato. So we began doing both ketamine and Spravato in 2019, and we've been doing that ever since. In 2021, after looking at our data and seeing that really what we were finding was when we did either TMS or ketamine, we were getting maybe a 70, 75, 80% response rate in that group of people who, if we had used another medication or kind of regular care, we would have been getting less than a 5% response rate based on the STAR-D study. And I can go into the STAR-D study if you'd like me to later. But that STAR-D study had really told us, and this was 2005, 2006, that if you had failed even 2 drugs, your chances of responding to a third were in the 20% range. If you'd failed 4 drugs, was in the 5% range. So really, really very little chance of responding. So if you see people who've been on more than 4 standard antidepressants, to me, I'm saying, knowing what I know now, they've probably been wasting their time and energy and resources in their life. So anyway, we thought I thought it was exciting. I thought it was worth kind of trying to get the word out on a little bit bigger venue. So we opened up a clinic in the Twin Cities area, and so we have a clinic there and a clinic in Rapid City, and they both do general psychiatry, but also treatment-resistant depression. So, just something that I've gotten interested in, and I think I've learned a lot about these things in the past few years. It's been very exciting. At this point, we've done something like 30,000 ketamine treatments and about 20,000, 25,000 TMS treatments. So we, you just gain some experience doing that, and we think it's been helpful, and we do this Q&A as part of a reach out to the communities so that people understand better what we're up to. So having given that little introduction, I've got I can talk about, as you might imagine, you probably don't want me to, but I can talk about this for days. But I'm interested in what brings you all here and what kinds of issues, what kinds of questions, what kinds of problems you're running into that I can sort of think through with you or be helpful at thinking about. And so I open the floor.
So good morning, Dr. Manlove. Thank you so much for this presentation. My name is Sherry Young. I'm a psychologist, and I work as a clinical educator and consultant. One of my clients is a treatment center in Edwards, Colorado, called All Points North. And so for the past 3 years, I've been referring people there. They do a lot of interventional psychiatry. And I have a couple questions for you. I'm curious if you're using RTMS or DTMS.
We use a machine that's called Cloud TMS. It is RTMS. There's one machine that does what is called deep TMS. That's a brainswave machine.
Yeah.
And I have a brainswave machine, and I think it works fine. But we prefer to use the other one, and the reason is basically that our results have been better. What we can do with the Cloud TMS machine that is not we can't do with the brainswave is we can put the wand that triggers electromagnetic stimulation in different places. We can move it around. So it's a wand that I can, place anywhere on the head or on the body for that matter. I mean, I actually treat back pain with it sometimes too. Whereas the brainswave that does deep TMS, it kind of locks it in place in one spot on the head and it's hard to move around.
Yeah.
So just to expand on that a little bit, there's one area that we know all the machines used to treat depression, and it works, and it's been studied a lot. It's right right where my finger is here roughly, and it's called the dorsolateral prefrontal cortex. Most treatments include that as part of it, but we also know, as you all probably know, that many people with depression have a lot of anxiety as part of their depression. And we have a way of treating anxiety with TMS also that's very effective, but that's on the opposite side. So then it's an inhibitory kind of stimulation, or it's not a stimulation, it's an inhibitory pulse. And so we do both of those. And so it's nice to be able to move around. And sometimes we treat the back of the head too, and sometimes we treat right here, and it gives us more flexibility. So that's why. And our data, we think, it's in my hands, it's better than Brainswave was in my hands. And that's why we use that.
Thank you for that comprehensive answer. I really appreciate that. And then my second question is, are you offering therapy in conjunction with either or both the ketamine and the TMS treatments?
We do in different ways. So that's a packed question, actually, especially with ketamine. So let me talk about TMS, therapy with TMS. For starters, you should know that when people get TMS, it does not affect their level of consciousness at all. They're distracted maybe a little bit by tapping on their head, but it does not make them sedated or distort their thinking in any way. So you can talk to people during TMS. You could potentially do therapy. What we've elected to do, which we think has been really useful and somewhat unique, and not everybody does this, is we do behavioral therapy when people are doing TMS. And that goes back to that observation that I had that people who exercise contemporaneously with TMS seem to do better. So when people start doing TMS in our clinics, we identify 5 behavioral issues to work on: exercise, diet, meditation, sleep, and socialization. And we develop goals in each of those areas with our patients, and we essentially coach them to work on those things. It's not like insight-oriented psychotherapy. It's like, let's figure out, how to, what most people who are severely depressed aren't exercising, for instance. Let's figure out how to get you to begin to walk a little bit, and let's develop some goals. And we see people every day when they're doing TMS, so we have a fabulous opportunity to work with them on lifestyle changes. So that is the kind of psychotherapy we do during TMS. We also suggest that people do TMS do psychotherapy on the side of TMS, because most people who are depressed have other issues of some sort. Depression creates lots of difficulties with families, with marriages, with other relationships, with work. Often there's comorbid PTSD or anxiety syndromes, that sort of thing. So we encourage people to do psychotherapy on the side. We do some of that in our clinic, but we really encourage people, if they've got a psychotherapist, to do that with their psychotherapist in the community. So that is the TMS piece. With ketamine, it's a little bit different story. You might have heard of, many of you probably have heard of ketamine-assisted psychotherapy. Does that ring a bell to you? And yeah, and that's an interesting issue. And I have a little bit different opinion on that than I think is the standard. Although I think I share my opinion with a lot of people. What we found with ketamine is that the dose that it takes to treat depression puts people in a dissociative state that is usually profound enough that they aren't able to do psychotherapy in any meaningful way. And also they're not able to essentially protect themselves emotionally. They're disinhibited enough. And so I feel very cautious about getting into issues like trauma and stuff like that when people don't have some of their normal defenses to kind of work around or work with during the process. So what we generally do, because we use doses that make, I think, psychotherapy difficult to do during ketamine treatment, we meet with people ahead of time or have them meet with their psychotherapist ahead of time and identify issues that they want to think through and work through while they're doing ketamine, and then also do psychotherapy, in between sessions. So that's how we do that.
Thank you. That's very, very helpful and very interesting.
What we do with ketamine is somewhat similar to what you'll see people doing with psychedelic-assisted psychotherapy. And it depends on which psychedelic people are using, but like with MDMA, people do psychotherapy as a major part of it. With psilocybin, there's more psychotherapy around the edges of it in general. And by the way, we're not doing either of those, and they're not FDA approved and they're not legal, so that's why we're not doing them. But I'm not sure if they are prime time or not actually right now. There's a lot of discussion about that, those medicines. Are you still stressing low carb diet with treatment resistant depressed patients, or maybe all of your patients? I attended the workshop, New Paradigms in Mental Health Treatment, probably back in 2014, and this intrigued me. What role does nutrition play in your treatments? Yeah, wow, that's a blast from the past. That was when we were just getting into this stuff. So it wasn't 2015, I guess it was 2014 when we were beginning to think about using lifestyle issues to treat depression. Yes, we do. I strongly suggest intermittent fasting as a brain health tool, and that we do it in ways that use a preponderance of fat for energy rather than carbohydrates. The reason this is similar to the reason why we encourage exercise. They both can cause ketosis and more ketone release, and ketones are an important way of triggering brain-derived neurotrophic factor. They stimulate that hormone, so it's a good way to improve brain health, and we think it improves people's response to any treatment that we use, actually. So yes, we still are very interested in that, in minimizing carbs and doing intermittent fasting. And just to explain what that is, intermittent fasting is eating the bulk of your food in a small part of the day, so say between noon and 7 or 6 or something like that. So that would leave you to fast between 6 and noon, which would be about 18 hours. And it doesn't need to be 18 hours, but anything moving in that direction triggers more ketone release because you've used up your carbohydrate reserves, and now you're beginning to use fat you're breaking down fat for energy, and that causes ketone release. So that's kind of the thinking behind that. So yeah, I think it's hard to get people to do, but I think that it's really important to consider. So that's one of those things that we do when I mentioned those 5 lifestyle things. It's one of the dietary things we talk with people about, is really reducing carbohydrates and simple sugars also. Example of a patient I had, a patient who was drinking, I think she told me she drank 12 bottles of pop a day or something like that. And I said, well, do you think we could reduce that a little bit? And she said, no, that is all I live for, the sugar from the pop. And so we worked with her during TMS, and slowly we're able to get her to reduce it. Well, can we cut it back to 10? Let's try 10, and okay, now let's try 8, and you got 9. Well, that's pretty good. You're moving in the right direction. I mean, it's a real coaching kind of strategy that we use for that kind of stuff. Let's see. Next question is, can these treatments help people with complex PTSD and trauma? If so, what happens to people when they receive these treatments, and what kind of support is available for them during the treatment sessions? So there's 2 different treatments that we're talking about here. Well, really 3. There's TMS, there's ketamine or ketamine-like treatments, and then there's brain health. So there's a couple of broad statements to make there. One is that to whatever extent their PTSD and complex PTSD and trauma causes depression, it helps depression. It doesn't necessarily help PTSD, but when depression is better, people can work through their PTSD better. It's like, they're just more able to take on a problem, to work through a problem. They're more motivated. They have more energy if they're less depressed. And these treatments, both ketamine and TMS, treat depression very well. The second kind of broad statement is that people with better brain health work through all problems better. So they're able to work through PTSD better also. Now, I think there is a special place, in addition to the treatment of the depression component, for treating PTSD or complex PTSD and trauma with ketamine or Spravato. They seem to put people in a better place to problem solve. It's think of it as I think of, metaphorically speak, at least, and maybe in reality, what happens when people take ketamine is they enter this default mode network. Have you ever heard of this? The default mode network. It's kind of it's the part of your brain that turns on when you're meditating or when you're not doing anything. When you're just daydreaming. But it turns out to be a part of the brain that, if you exercise it or allow it to happen, um, it people put together different ideas in different ways. For instance, it can be going to that part of your brain can make you more creative. People can, and we think about creativity, at least in a very simple way, as you're bringing in a couple of different thoughts that you weren't normally connecting, and now they come together, and there's this new idea that comes out of that. So you can put you in a position to be creative and to, I think, problem solve too. So I think PTSD can be, I think that we can use this tool to treat PTSD. We can put people in that network and then see what they come out of the PTSD with, and process how their brain is working through their traumas better. And they might have a bit more creative capacity to do that. And just on a strictly neurological level, but one of the things that happens with PTSD is we literally see brain growth. We see dendrites growing. We see increased connectivity of the brain, of the neurons in the brain. We actually, you can see using very sophisticated imaging tools that the brain is more dynamic and plastic, more plastic meaning more mobile, more changeable, more flexible. So you can, I mean, I imagine that is what neurologically gives people a little bit more capacity to work through all kinds of problems when they're on ketamine, but also when they're when they're dealing with trauma. Does that make sense? I don't know if that answers that question to some degree, or any follow-ups to that question that anybody has?
I might, if that's okay.
Sure. Yeah.
My name is Cassandra. I'm a therapist in the community and I offer EMDR. So anecdotally, I have heard people talk about what ketamine treatment has been like for them. So I'm really curious, like whether the way they speak about it sounds like as if it's very it's like almost parallel to EMDR. So I don't know what your thoughts are about it, whether there is a similarity.
I believe there is, but that's a broad statement. So let me just back up. When you look at the brain, if you look at very sophisticated imaging tools that look at the brain, it's really kind of fascinating to me. When people are depressed and when they get better, what their brain looks like depressed and when it gets better, it looks the same whether they're treated with Prozac, EMDR, psychotherapy, ketamine, anything. And what we see when people are depressed is that there's much less plasticity. It's atrophic and hypoplastic. And if they respond, if their depression goes away, they have increased plasticity. So I think there are lots of ways of increasing neuroplasticity. And I don't think that I don't think and I don't think they should be done in isolation. I think it's stronger to use a variety of tools to improve that. So for instance, that's why I mean, even though there is evidence that people who exercise without anything else have improved moods. If somebody comes in and they're dying from depression, I don't say, well, go exercise. I mean, I do say exercise, but I don't just say that. I mean, I say, let's do something, there's something, we need to go faster. So I say, let's do, the fastest way we can treat this. And in my mind, that's usually ketamine or TMS. But then let's do these other things also, because if we do exercise and a ketogenic diet or, intermittent fasting or improve socialization or do EMDR or work through a problem in your relationships, that is all synergistic with this process of improving neuroplasticity. And I think when you add them together, you get a better result. So I haven't actually seen a study looking at for instance, ketamine plus EMDR, but I have based on my experience, I would say that there's a synergistic value to doing them together. That makes sense?
Thank you.
The next, I guess Cassandra asked, what is the frequency of ketamine treatments and how often does a client receive ketamine infusions? Weekly or whatever. Okay. So in the early studies of ketamine back in 2000, they did a single dose of ketamine. And what they found was that a single dose resulted in a fairly significant drop in depression. Unfortunately, it didn't last. So it would last for maybe a day or so, and then it would go away. So what people began doing was stacking up sequential ketamine treatments. So and to the point that nowadays, when we treat with ketamine, we have a standard kind of plan of giving 2 or 3 treatments per week for the first 3 or 4 weeks. And then we begin to taper it off. And we might taper it to once a week for starters. And then we try to taper it off as far as we can. And maybe it's once every 2 weeks, maybe it's once a month. And we monitor in between for how long does the depression stay under check. And if it stays under check, then we go far longer and longer in between treatments. I do have patients who I've treated with ketamine who will come in and will do, say, 6 or 8 or 9 treatments. They feel fine. We stop and they go away. We don't hear much back from them. And then 6 months later, or a year later, or never, I hear from them again. And they say, it's coming back. Could I have a few more? So that is another way that we do it. We sometimes do bursts. And that's pretty handy for people who are living in rural areas, right? So they don't have to come into town as often. Or I got patients who come from Alaska, for instance, and they have connections with Rapid City or Minneapolis, and they'll come for treatments in these places, but they can't get them in Alaska, maybe. So this is a good tool for them. Spravato is about the same. Generally with Spravato, and this is based on what insurance will cover, they will cover 2 treatments per week for the first 4 weeks, then 1 treatment a week for the next 4 weeks, and then whatever people need after that. So it's similar. And just to kind of piggyback on that question, that issue, most insurances do not cover ketamine, but most of them do cover Spravato. We do both because a lot of people don't, a group of people don't respond to Spravato and do respond to ketamine, so we end up doing both at different times.
Pardon my new knowledge. What's the difference between ketamine and Spravato?
Yeah, okay. Good question. So they're very similar. I think it's you can say to a great extent they are the same drug. So in molecules naturally come in sets. They come in mirror images of each other. Just like my hands are mirror images of each other. This hand looks at this hand that sees the same thing, but they're actually different. So molecules come in mirror images of each other. So ketamine is the right and the left mirror image, or they're called enantiomers. And Spravato is just the left one. So that's how they're different. They had to make a new molecule. It's just a convoluted statement of the modern medicine. They could never FDA approve ketamine for depression because it was too expensive to do that, and the reason it was too expensive is it costs millions of dollars to do, and ketamine is already generic, so they could never sell it for enough to cover their FDA approval process. So Janssen, the company that made Spravato, they made a new medicine that they could patent, which is not ketamine, but is actually the generic name is S-ketamine. S means the left enantiomer. So they made that, and then they were able to patent it, and then they could spend literally hundreds of millions of dollars to get FDA approved, and then they can get it covered by insurance. But ironically, now Spravato or S-ketamine costs approximately 100 times more than ketamine does. But insurance coverage is only for Spravato or S-ketamine. So it's a strange world we live in, and that's one of the small strange things that are in the world that I live in. So they're very similar medications. The other thing is Spravato is given intranasally. Ketamine can be given either intravenously, intramuscularly, or intranasally also. There are a lot of online companies offering ketamine treatment. Are they the same as ketamine infusions? Is there a difference in the outcome? Yeah, great, very important issue. Issue that's I'm pretty concerned about. Yeah, they are offering the same ketamine that we use in our clinic. They offer them in different ways. Sometimes they offer them in there's a pill form like a lozenge. They offer them you can get intramuscular or intravenous ketamine online too. And the problem is they aren't different than what we offer, and they're dangerous to do without supervision. And so I have major concerns about doing that. I mean, I've personally observed lots of not big problems, but problems that require support from ketamine usage. And it really, I think it's very dangerous to have somebody unsupported in the community taking ketamine on their own. And I think that's what we run the risk of happening if you send people ketamine or give them ketamine to take home. So we don't ever give people ketamine outside of our clinic. Just as an example, just from a strict liability, but it's also because we're concerned about people in the community. I mean, if I gave a patient ketamine and they used it and then they decided they were going to go drive downtown and they got in a car accident, they would be more likely to get in a car accident, and I would have some responsibility for that. And so that's a story there. And of course, many of you probably know the Matthew Perry story. Does that ring a bell to some of you folks? The guy who was in Friends who died of a ketamine overdose. And it appears that what happened was he was getting ketamine in a clinic, but he also was getting ketamine to take home, and that's what he ended up taking an excessive amount of ketamine at home, and apparently hopped in a hot tub and didn't bother to breathe when he went underwater and died. And it probably was not a suicide attempt. It was probably an accident, just because he was not able to make good decisions when he was on that high a dose of ketamine. I mean, it might have been a suicide attempt. I don't know, but it's quite easy to believe that it was just an accident.
Thank you so much for answering my questions.
Sure. There's a question here from Julie Hurley. Have you used TMS in adolescents? And how does it interact with comorbid disorders like ADHD and ODD? How effective is the treatment? What is your experience with health insurance covering this treatment? Yes, we have. It is a fabulous treatment for adolescent depression. It happens to be very effective for comorbid ADHD and ODD, and insurance doesn't want to cover it. So let me just back up on that, those series of statements a little bit. So first of all, TMS is FDA approved for treating adolescent depression. So it's been studied, it's had all the bells and whistles that need to be done to get it FDA approved, and it's been proved to be effective. And in our hands, we've treated several adolescents with TMS. And why do we do that? For one thing, I think it is the safest treatment, medical treatment for depression that we have. There's no side effects from it. Essentially, it doesn't change your mental state at all. It doesn't interact with any other medicines you might be on. It doesn't cause any physical symptoms of any kind, even in the brain. It does cause symptoms at the time of treatment. You feel a tapping feeling, and it's a strange feeling. I've done it myself. Everybody in my office has tried it, and we because we all know it's completely safe. We would never, worry about. I don't worry about treating anybody with it. And so why wouldn't you use the safest treatment you could with an adolescent or developing brain, and if it's FDA approved? The other thing is to be when thinking about the dynamics of depression. Remember that adolescents have more neuroplasticity already than any other well, except for children have more than adolescents, but any day after as they get older, they're going to have less and less neuroplasticity inherently, and really so they're probably more able to respond to neuroplasticity inducing treatments, and that's what we phenomenologically see when we treat people with TMS. So and it turns out there actually have been studies done treating ADHD with TMS, and it works very well as a standalone treatment for ADHD and ODD. And when you think about it, what are we doing when we're treating TMS? We're stimulating right here, which is the prefrontal cortex. And the prefrontal cortex is a part of the brain that kind of helps manage the communication of emotions between the frontal cortex, which is kind of helping you manage. So it helps you manage, the frontal cortex help you manage impulses. And if you strengthen that connectivity there, you probably are going to decrease the impulsivity piece of ADHD. And that's what phenomenologically appears to happen. So it really is the only way we should be treating depressions. It's, does anybody know? Probably not. There's only, one drug that has been FDA approved to treat depression, and that's Prozac. So, there's really no other FDA approved options almost besides TMS, and yet insurance companies aren't covering it. An interesting, I had a woman, a young lady who was 17. She turns 18 in June, and I just had a review with the insurance company about this, a peer review. I'm talking to another psychiatrist, and they're supposed to be able to make exceptions, or at least theoretically. So I talked to him. I said, you're aware that it's FDA approved. You're aware that there's no side effects. I don't, can you explain, isn't that enough? Can you, she's 3 months away from being 18. He said, no. And I said, well, so you're willing to, she's severely depressed, suicidal. So you would rather have her die than have her treated with TMS at this point. And he said, well, yeah, we don't think she'll die. That was, but anyway, there wasn't any way. He said, our committee has decided they're not going to cover that, and so I'm not going to agree to it. And even if it's immoral, unethical, bad science, whatever. So I guess that's another thing about the way the world works, another life lesson about life in the current era. Yeah, let me, oh, why can't I do this? Oh, I see what I'm doing. I'm leaning on my keyboard. Okay. Yeah, other questions, other thoughts people have, other thoughts that I've triggered by my discussion so far.
Looks like there's one more question in the chat that says, what is the cost per treatment for TMS?
It depends. I mean, so what we normally charge, and it's normally covered by insurance for starters, and TMS is covered by all insurance companies at this time. And if people pay out of pocket, which is fairly rare, I think our standard cost is $225 per treatment. But you got to remember, there's a lot of treatments. With TMS, we do 5 treatments a week, usually 5 days a week for 6 weeks. So that's 30 treatments. And we do 1 day a week for 6 more weeks. So it's a total of 36 treatments. We do, in our clinic, we do slide the fee scale depending on people's needs and financial situation. So yeah, that's what it basically costs. And with ketamine, when it's out of pocket in our clinic, we charge $350 per session. And if we do it, that's for IV ketamine, and we charge $300 for IM ketamine. And that's, yeah, so that's basically the cost for us. We do not, Spravato is just too expensive for people to pay for out of pocket. We don't have anybody doing Spravato out of pocket because of that. And then the question is, so insurance covers TMS, just not for those under 18. That is correct. Yeah, almost all insurances cover TMS, but they do have criteria. So for instance, they have to have failed varying amounts of antidepressants. Usually it's at least 2 antidepressant failures, usually a psychotherapy failure. That's about the minimal amount of failures that you have to get insurance to cover TMS. Some of them require 4 failures, and and maybe sometimes augmentation agents also. So there are somewhat variable, but at least in the people we see, everybody's failed lots of things, and it's pretty easy to get people covered. It does kind of beg the question, why, if it were my spouse or my kid or somebody I cared about deeply, would I have them wait to fail 4 medicines before treating them with TMS? No, I've got one in my office. That is the best way to treat depression. That's what I would do. In my mind, it is the most effective, most benign, side effect-free treatment. So, I mean, I'm not saying it's the only way to treat it. I'm just saying it happens to be very effective and have very few side effects. Next question is, after treatments of TMS for 36 weeks, does one have to come back for more years down the line? So interesting. So our experience when we started doing ketamine or TMS was that it seemed like it had a really persistent effect. We would finish up those 36 treatments, and we just didn't see relapse very much. So eventually I did a study, and I looked at the people we did TMS on, the next 100 people we did TMS on, and it was just an observational study within my clinic. But we We also did all the brain health stuff that I talked about, those lifestyle issues, but also did, as part of our brain health treatment, we do a very, very broad medical panel looking at all the hormonal levels people have, mineral levels, vitamin levels, metabolic issues that they might have, and developed a medical plan for treating all of those issues. And by the way, we found a lot of them, my observation was this was really contributing to the treatment resistance. When we treated all those and did the lifestyle things and did TMS, we had about a 10% relapse rate per year. In other words, once we treated somebody, they had about a 10% chance of relapsing in the next year, which is really, really phenomenal. In depression in general, people who've had depression, who've had a good result to treatment of any kind, pretty much have about a 50% chance of relapsing in the next year. And it's true for just TMS alone too. If I compared my results to other TMS clinics, and generally TMS clinics who weren't doing anything more than TMS were having about a 50% relapse rate. And the only thing different that we were doing was the brain health treatments, the medical treatments for all of their subtle medical problems and the lifestyle issues. But when we added those together, we were seeing about a 10% relapse rate. So it wasn't as good as I thought it was when I first was, thinking, boy, maybe this is curative. Wasn't quite that, but it was pretty good. And I've seen people go years after TMS without relapsing. But I do think that they do much better if they have their actual medical problems treated with the TMS, and if they make lifestyle changes to stay healthy. Just to back up on that just a little bit. So what am I seeing that why isn't their primary care doctor seeing these medical problems, and why am I picking them up? The reason is that I'm doing a much more extensive panel, and I'm interpreting them a little bit differently than primary care docs do. So if you're depressed and you go to your primary care doctor, the standard medical workup, and what is people have felt has been appropriate, and what I did myself was in the past was you do a metabolic panel and a CBC, and you do a couple of thyroid tests generally. And if those were normal, you said, well, it's probably not. They're probably, and they do a physical exam too. If everything seemed fine, then it's probably not related to a medical problem. So when I do this lab panel, I'm looking for subtle medical problems, not ones that are highly overt. So most medical problems, just like depression, there's a continuum, right? So you might be feeling okay, but you're not feeling well, and yet you're not sick enough to really call it a disease, right? And maybe that's because your thyroid is in the normal range, but maybe it's in the low normal range. And you really would feel better if it was in the what I call the robust normal range. So get it above 50% above, above 50% of the normal range. That I call the robust normal range. So when I'm looking at, for instance, thyroid, I look for subtle abnormalities, and then I push them into the not supra physiological, not above the physiological range, but in the physiological range, but in the supranormal physiological range. And that I think makes a difference. And I've seen, just speaking of the thyroid issue, I've seen many people who have a dramatic improvement in their mood almost within a short time, within a few weeks, by just getting them into a above average range of thyroid functioning. But if you're just looking at the TSH and maybe the T4, which is the other standard test that's done, and they look normal, and so you say everything is fine. So that's how we've broken it out differently, and I think it's resulted in really great responses. I see our time is running out here, and I know that many people may need to go. I do have a little bit more time if people would like to go a little bit longer, if people have other questions. But it's fine to, you don't. I understand that people may be leaving, so that's fine. So I'm just looking at other questions, but if people have questions you'd like to just throw out, I'd be happy to talk some more. Anybody have just sort of other nuts and bolts kinds of questions, like how do we assess people? Maybe that's worth just talking a little bit about. So when people, so what I'm interested in, what our clinics focus on, in addition to just general psychiatry, is that group of people that haven't responded to other things. So in my mind, from the get-go, I'm saying to myself, okay, this is a person who isn't responding to anything. Why? And then I'm also thinking, if their depression is severe, which very often it is the case in people that end up in our office, this is a dangerous situation. They have a severe depression, which we know is a life-threatening illness, and they haven't responded to anything, and they're demoralized, and they feel like nothing is going to help now. Very common experience. So we kind of start out by saying, we're going to do a full court press. We're not just going to do the next antidepressant or something like that. So we usually spend about an hour and a half for our initial evaluation. We go through their history. We go through every medication they've been on, because every medication is a biological probe of its own kind. And it tells us something about what they're responding to and not responding to. We look at all their medical history, if they've got other medical problems that might be contributing, and social history and all the things that you would normally do. But then, in addition to that, we do we invite people to do a very broad lab panel. So as I mentioned before, we check hormone levels, thyroids, sex hormones, cortisol levels, adrenal hormones, metabolic issues, minerals, zinc, copper, magnesium, metabolic factors like lipids and blood sugars and hemoglobin A1Cs, because all of these things, if they're off, can contribute to depression and to poor brain health. The other thing that we invite people to take part in, at least if they will, is we generally do genetic testing. Because again, if we're going to do a full court press, let's find out if there are any markers that might tell us things that they're more likely to be responsive to or less likely to be responsive to. And do they have any genetic factors that there are some genetic factors that we can off the bat treat, and if we treat them, their depression is likely to get better no matter what we do. I don't know if any of you have heard of it's called the MTHFR genetic factor. I'll tell you the name. It's methylene tetrahydrofolate reductase genetic factor, and if people have low levels of that, and it's fairly common, they don't turn folic acid into the active form of folic acid. And the active form of folic acid is what is required to make neurotransmitters. So they don't make neurotransmitters efficiently, and that can cause depression and anxiety. And it turns out that we have methylated folic acid products that are cheap and on the market that we can put people on to just fix that problem, without doing anything more. So it's super important to know about in my mind. So we do the genetic evaluation, we do the lab, we decide if there's anything we can do with medications that might be more useful. And then we go to insurance and try to pre-authorize either, in our case, usually it's either TMS or Spravato. And then we get going with a treatment of one or the other or both. And while we're doing that, we're encouraging people to either do psychotherapy in our office or with a person who might have referred them to our office. So it's a pretty extensive evaluation, I guess, is my point. And I think that we are hitting the things that I know about that can be helpful to treating treatment-resistant depression. Another question came up. After TMS treatments, are patients able to reduce medications? What about interactions with antipsychotics such as Seroquel? Yes, they are often able to. And so what we do, and it's why we like to follow patients ourselves during TMS, because as people get better, well, let me back up. Often the medications that people are on when they're starting TMS aren't effective. That's why they need something more. But we don't know how effective they are, because maybe they'd be doing worse without them. So we usually start TMS and then try to taper off medications while they're on TMS. And sometimes we taper off all the medicines. Sometimes we'll be tapering them and all of a sudden they'll do a little bit worse. And we'll think, well, maybe the one we just tapered was giving more benefit than we thought. So maybe we'll restart that. But our goal is to back off medications as much as possible. What about interactions with antipsychotics such as Seroquel? TMS works fine with antipsychotics. There's no interaction that's a problem. And specifically, there's no major interaction with Seroquel that we see being problematic. Well, good. I'm hopeful that this was of some value to you folks. This is a problem that is very, near and dear to my heart, something I care a lot about, and have some level of excitement about the ability we have to help some folks who are really suffering. So I hope this gives you some other ideas yourselves. Thank you for coming, and I appreciate all of your questions and your attention. Have a great day. Take care.